Good evening, all. Today is the fifth annual International Nash Day, observed every year on second Thursday of June. It is an educational campaign to raise visibility and urgency around non-alcoholic fatty liver disease, that is NAFLD, and its more advanced form, non-alcoholic steatohepatitis, that is NASH, which affects more than 115 million people around the world. Because NASH symptoms are not overt, often it is underdiagnosed and underreported. NAFLD and NASH are major risk factor for concurrent obesity, type 2 diabetes, hyperlipidemia. So, if it is unchecked, it leads to cirrhosis, liver cancer, even the liver transplant. Again, this backdrop of global goal of today's initiative taken by USV with support of IJCP is to raise the awareness about NASH among medical professionals and the global public health community. To discuss it further, we have an expert today with us, Dr. Professor Vijay Panikar, Consultant, Department of Endocrinology, Diabetes and Metabolism, Lilavati Hospital, Mumbai, ex-Professor of Medicine, KG Somaya Medical College, Mumbai. So welcome to the chat show.
Thank you, Santosh.
Sir, yes, sir. Sir, before going to start, I just want to understand from you, NAFLD has emerged as a leading global cause of chronic liver disease in the past few decades. So, need your discuss on highlight that NAFLD is and what is the progression, why and how NAFLD turned into NASH. Over to you, sir.
Santosh, basically, like you said, we are just seeing the tip of the iceberg today because of lack of physician awareness, lack of that need to really investigate patients with NASH. It's just a tip of the iceberg that we are seeing. It's a huge problem worldwide. And in fact, now in the US, liver transplant secondary to NASH is becoming very high up in the hierarchy. So that is where NASH is. Now, what exactly is NASH? It is non alcoholic steatohepatitis. So it is non alcoholic and it is basically a diagnosis which rules out other causes like autoimmune hepatitis, hepatitis C, hepatitis B, Wilson's disease, hemochromatosis, all that is out, alcoholic hepatitis. And then what remains? And still, if there is a fatty liver, that is what NASH begins with. So, non alcoholic fatty liver disease. And what really causes it? It's very simple. It is accumulation of fat in the liver. There is excess storage of fat in the liver. And that excess storage of fat in the liver leads to a inflammatory reaction which would damage the hepatocytes, would lead to destruction, fibrosis, ballooning, and that is how the liver gets damaged. And this can progress to cirrhosis, and if it still continues, it can progress to hepatocellular carcinoma. This is how NASH is there. Now, why is there excess fat accumulation in the liver? That's an ectopic fat which is getting deposited. Normally, the fat is stored in the subcutaneous tissue. And if the fat cannot be stored in the subcutaneous tissue, it gets deposited into the liver. So, what causes that? Very simply put, it is insulin resistance. When you have significant insulin resistance, the subcutaneous fat has a very limited pocket of resource to absorb the fat, and that gets deposited in the liver because with insulin resistance there is mobilization of free fatty acids and all that gets deposited into the liver, and that is where the crux of the matter begins. So just to complete that, so who are the people who are likely to have fatty liver? These are the ones who classically have insulin resistance. Who are the ones who have classical insulin resistance? The obese, the sedentary lifestyle, the ones with truncal obesity, These are the ones who are likely to have insulin resistance. And Indians across the world, the Indian phenotype is an insulin resistant phenotype. And that is where the main worry for India and Indians is the outcome of NASH in our population.
Yes, sir. Sir, the way you explained, it's something like it is not simple, which you are not supposed to neglect it. We have to treat it. That's what I just understood from your discussion, which we
Yes.
not give the proper importance till now. So there, that is, but of course, you told that it is a epidemic in US. We have told the example. So, what is the like? What you feel that what is the prevalence of India with having NASH?
See, we really don't have any proper figures for India. No extensive study has been done to give out figures. But if you look at across the world, about 2.8 to almost 46%, depending on the type of subjects that have been taken. But if you look at Indians, we are an insulin resistant population. So, extrapolating that, it would mean that we have a huge burden of fatty liver just waiting to explode in front of us. And in clinical practice, Santosh, what we see is when you routinely ask for a sonography of the abdomen for a diabetic patient, I think 7 out of 10 you will get fatty liver, grade 1, grade 2, or whatever. So that is the extent of the disease, and we have not been able to really look at it in. We don't have real data from India at the moment.
Yes, sir. Because as you rightly said, patient come for some other diseases. When you do some sonography, then you come across the patient having NASH. So coming to the same, if any patient come to the clinic, what is the clinical sign and symptoms you look out for the NASH? And if yes, what are the tests you prefer?
See, basically, when you talk of NASH, that is one step ahead of a non-alcoholic fatty liver. When you say NASH, it is non-alcoholic steatohepatitis. That means there is a hepatitis secondary to the steatosis, that is accumulation of fat. And that means you will have the liver enzymes which are elevated. The SGOT, the SGPT, the gamma GT, these enzymes would be elevated when you say NASH. When you talk of just a fatty liver, non alcoholic fatty liver before NASH, it is just an accumulation of fatty acid, fats. There is steatosis, but no hepatitis. So there are basically in this there are no symptoms. Patient has no symptoms. It is just that you have to have that high index of suspicion to really look for it. And what we do in our practice routinely is new patients who come, especially who are obese, we routinely ask for a transaminase levels, that is your SGOT, SGPT levels as a routine. And if he requires a sonography, yes, we do. If the OTPT is high, then we may look at other markers to rule out HCV, HbSAg, etc., and get a sonography also done. The fibroscans and all come much later.
Yes, sir. Sir, you put a one nice word like no symptom, and you have to identify in other manner the patient has NFLD or NASH. So, coming to this, like, can you go ahead? Always think about a risk factor for an NFLD or the whatever the risk factor which you feel they may end up in NFLD or NASH.
Yes. See, what are the risk factors for developing NASH? What is NASH? Like I said earlier, it is accumulation of fat in the liver. Why does it accumulate? Because that patient has got excess fat in him, which cannot be stored in his subcutaneous tissue. This is ectopic deposition of fat. So, obese patient, sedentary lifestyle, those who have a central obesity, and Indians have central obesity, those who have excess visceral fat. And all these characteristics are typically seen in an Indian population. They're thin, fat Indians, they have a central obesity, they have insulin resistance in a big way across the board. One of the studies we did, We have a metabolic syndrome in almost 79% of all type 2 diabetics. That's huge. And today, metabolic syndrome has been considered just a manifestation of fatty liver. Every metabolic syndrome is a potential for fatty liver.
Yes, sir. Sir, if this is nearly 40 to 50% of the diabetic patient have one or NFLD or ASH. So the one thing I just definitely want to ask, what are the risk factor for that? Like, what are the consequences if it is not treated properly?
See, if it is not treated properly, over a period of time, it is going to progress. 100%. From NAFLD, that is just a steatosis, which means that there is about 5% fat in the liver. Once the fat amount increases, that steatosis becomes a steatohepatitis. Because of that accumulation of ectopic fat in that liver, it sets up inflammation. And that inflammation causes a hepatitis. So there is, and that leads to destruction of the hepatocytes, fibrosis, and that is how the disease progresses. So the next step after this would be that the patient lands up in cirrhosis of liver. So non-alcoholic cirrhosis. With cirrhosis remaining there, in cirrhosis you have small nodules, large nodules, and so on, that regenerating nodules, and that becomes a nidus for developing hepatocellular CA. So hepatocellular CA is the ultimate. But the immediate here is after a steatohepatitis is cirrhosis of liver. That itself will increase the mortality and morbidity of the patient.
Yes, sir. The silent without no same problem with this leads to
Exactly.
so much complication in the future. So definitely, I want to ask, like, sir, what medication you have to prove effective in treatment of NASH or the NFLD?
See, Santosh, there are many medicines which have been tried. Many. But let us look at what is the basic pathophysiology. The basic pathophysiology is that because of insulin resistance, there is release of free fatty acids which gets deposited into the liver. Specifically because these subcutaneous adipocytes don't have the capacity to take on this excess fat. So if you treat insulin resistance, you will be doing a yeoman service to your patient right from day one. And how do you treat insulin resistance? You have diet, exercise, and medication. All these are aiming at weight reduction. Now, if you look at, if you have a 5 to 10% weight reduction, superb results, you can get reversal of the Nash. If you have about 15-20% weight reduction, you can almost cure it in the early stages, I mean. All right. You do a bariatric surgery, excellent results on Nash with bariatric surgery. What are all these mechanisms doing? They are reducing the weight of the patient and thereby reducing insulin resistance. Full stop. When you talk of drugs, GLP-1 has been shown to have some beneficial effects in Nash, again by virtue of weight reduction. SGLT2 inhibitor also has been shown to have some benefit secondary to weight reduction. But the drug which treats the basic pathophysiology, that is insulin resistance, is pioglitazone. What pioglitazone does is very simple. It reduces insulin resistance, and by doing so, it increases the capacity of the subcutaneous adipose tissue to take in more fat. So when a patient is on pioglitazone, his subcutaneous adipocytes, the number and the size increase. So there is more reservoir to take in the fat, and that is how it affects and treats NASH. No other molecule can do that. All the others are doing it with weight reduction. And that is where pioglitazone causes a weight gain because the increase in subcutaneous fat. But all the studies that have been done There has been a study by Kusi et al., which was presented, where he compared all the different treatment modalities, and the best effect was seen in those on pioglitazone as compared to even liraglutide. All the others, you have so many drugs in the lineup there, but none of them really have shown as good an effect as pioglitazone. So this the treatment has to be the treat insulin resistance. So lifestyle modification, weight reduction, and pioglitazone. Now pioglitazone has a problem that is it is not yet approved for fatty liver. But if you have a diabetic patient with a fatty liver, pioglitazone is the drug of choice. But in a non-diabetic, using pioglitazone becomes an off-label prescription. Though it has been recommended by some of the guidelines, but it becomes off-label. So here, vitamin E, there is a previous study which had shown that vitamin E can also be of benefit. But I personally feel you have to treat insulin resistance to get the best benefit.
Yes, sir. Of course, the pioglitazone is the molecule which is helpful to reduce this problem in future. So, you told about the guideline recommendations. So, what are the guidelines which will recommend pioglitazone in this condition?
See, basically, when you talk of guidelines recommending pioglitazone, basically, if you talk of ASD, the EASD has said
Yes.
that yes, pioglitazone has good data. There is no question about it. But it is not recommended in non-diabetics. And there, vitamin E would be a better choice. Though I would say if you have definite evidence of insulin resistance, then you should treat those patients with pioglitazone, as has been shown in the IRIS study. IRIS study were non-diabetic patients who had insulin resistance who were treated with pioglitazone, and they showed a reduction in secondary stroke, etc., etc. So indications would come once we have more studies and other things that come in, but it can be used. Then there are other guidelines like the liver societies and which also have recommended pioglitazone. In fact, all these studies have shown that pioglitazone is the number of studies which show the benefit of pioglitazone. No other molecule can compare with that. But
Yes.
unfortunately, pioglitazone had some bad experience. There was this episode of bladder cancer and increase in weight gain, increase in heart failure, increase in obesity, which has made the use cautious. But now that bladder cancer story has gone out, but still, obesity, putting on weight, and heart failure still is a problem which have to be maintained, thought of. So you have to weigh the pros and cons in a given patient before you initiate pioglitazone.
Yes. So, coming to this basic, like nearly 40 to 50% of the diabetes, assuming that they have NFAD or NASH. So, how you like management of diabetes and NFAD is a similar way, or there is any change with the patient have diabetes plus NFAD?
See, Santosh, basically what you have to see is in Indians, now I'm referring specifically to the Indian population. There are, when a newly diagnosed diabetic comes in, what is his problem? His beta cells are not functioning well and he's got insulin resistance. And if you look at insulin resistance per se, forget everything else. It is the biggest risk factor for a patient because that is the cause of macrovascular disease, that is the cause of NASH, that is the cause of PCOS, that is the cause of sleep apnea, that is the cause of hypertension, dyslipidemia. You name the thing, everything comes into that, including increase in heart failure. So every type 2 Indian diabetic, you should treat insulin resistance. And how do you treat that? Use of a pioglitazone and a metformin combination. Here, you are worried about weight gain. You add a SGLT2 inhibitor to that. Today, SGLT2 has become generic. It is very cheap. So you have a metformin, a pioglitazone, and an SGLT2. This combination, to my mind, would be ideal unless there is a contraindication for any of these molecules in the patient in every type 2 diabetic, Indian type 2 diabetic. It will address insulin resistance, it will address NASH, it will address all the other macrovascular complications. And if it is started early in the history of that diabetic patient, the earlier you start, the better the outcome. Excellent outcome.
Yes, sir. Sir, you discussed that NFLD is a pathological ectopic fat accumulation combined with a inflammatory state. So that means I will take it that there is a higher risk of cardiovascular risk for this patient. If it is yes, how we have to physician have to manage atherogenic dyslipidemia along with the NFLD to reduce future cardiovascular risk?
See, the cardiovascular risk increase is not directly related to NAFLD. That NAFLD is because of insulin resistance. And the cardiac outcome or bad cardiac outcome is also because of insulin resistance. So that is the key. That is where the source of the problem is, insulin resistance. And has been shown very nicely in the IRIS study, where they did in patients who had a stroke, they have given pioglitazone, those who have insulin resistance, non-diabetic patients, and have shown reduction in secondary stroke by 24%, myocardial infarction by 24%. So that is where the problem is. So it is not NASH, it is not alcoholic or non-alcoholic fatty liver disease which is causing the heart problem. It is the basic pathophysiology which causes the fatty liver, which is causing all the other problems. So you treat that basic problem and you will do well for the patient.
Yes, sir. You sir rightly said that future cardiovascular risk benefit may a patient may get it if it is treated early. So coming to another factor, like India is also have a highest number of pre-diabetes, and NFLD is also start with this patient with pre-diabetes. So you have any experience or any evidence of benefit of pioglitazone in pre-diabetes patient?
See, there are n number of studies where in pre-diabetic patients in the diabetes prevention program they have used pioglitazone. You had initially the tripod study, which used proglitazone. You have the pipod study with pioglitazone, and you had the ACT Now study. Ralph DiFranzo has done that, where they show that giving pioglitazone reduces the chances of new onset diabetes by almost 70 to 80%. So that what is pioglitazone doing? Treating insulin resistance. What is all the diabetes prevention program doing? Treating insulin resistance by diet, exercise, and lifestyle modification. Simple. And here again, I would like to go back to that IRIS study, which was done in non-diabetic patients, where they had a subgroup of almost 2,800 patients who were pre-diabetic, not diabetic, pre-diabetic. And there the outcomes were fantastic. The new onset of diabetes almost came down by 80%. The stroke and new myocardial infarction or acute coronary syndrome reduced by 40%. So it was just treating insulin resistance which has given these benefits. So you could treat. So lifestyle modification, weight loss is the key. Though we don't have any guidelines which recommend that you use pioglitazone in the pre-diabetic. But I would say though we have studies which show the excellent benefits, we can definitely consider using it in patients who are high risk and who already have an established NAFLD or a NASH and who are pre-diabetics. Definitely use pioglitazone and lifestyle modification.
Yes, sir. Sir, you discussed mainly that insulin resistance is one of the point factor which leads to a lot of complication in future. So, if the pioglitazone works on insulin resistance, definitely there may be a more benefit which we call a pleiotropic benefit of pios. If you have any pleiotropic benefit if you use pios in your patients, sir?
See, rather than saying pleiotropic benefits, I would say what are the benefits of Pio? See, it reduces insulin resistance and has been shown in many studies. It does wonders. Like you had the proactive study. Proactive study was done in patients who already had a myocardial infarction, where they showed that secondary myocardial infarction comes down. Stroke came down by 47% in the proactive study. Then you have the Chicago study, which talks about the cranial intima media thickness. You have the Periscope study by Steve Nissen. What did Periscope study tell us? That when you give pioglitazone as compared to a glimepiride, the intravascular thrombus reduces significantly with a pioglitazone, whereas it increases with glimepiride. So, pioglitazone is an anti-atherogenic agent. And there are many studies which have shown that pioglitazone is anti-atherogenic. And the main are proactive, Chicago, Periscope. These are the studies which have shown the anti-atherogenic properties. And there are many other studies of meta-analysis which have shown that. So if you can have an anti-atherogenic drug which would treat insulin resistance, reduce all these complications, including Nash, what more do you want?
Yes, sir. That is the summarize of everything, all the pointers. But I want to ask one question on behalf of all the doctors which is listening to this.
Yeah.
You give many benefit of pioglitazone. So if you have any preference for the patient, like you will use a pioglitazone to get the maximum benefit.
Come again, I didn't get you.
Yeah, how to choose the patient for pioglitazone therapy for the maximum benefit?
See, you have to establish that the patient has insulin resistance. Every type 2 Indian, almost 80% of them have insulin resistance. Now, when you have insulin resistance, what do you have? You have a central obesity. The patient is obese. That's his phenotype. He could have acanthosis. He could have skin tags. These are all clinical features which tell you that patient has got insulin resistance. Biochemically, you look at the lipid profile. Insulin resistance has a very typical lipid profile. You have a normal or slightly elevated LDL cholesterol, but it is mainly a small, dense LDL cholesterol which is very atherogenic. You have a HDL which is low, and you have a triglyceride which is high. So, a low HDL, high triglyceride, and low dense LDL cholesterol, not very high LDL, but all right. Now, this is a typical dyslipidemia secondary to insulin resistance. So, this tells you that there is insulin resistance. And if you're more academic, you could do a HOMA. You do a fasting blood sugar and a fasting insulin, and there is a formula to calculate the HOMA. If the HOMA is more than 3, you may definitely consider that this patient is insulin resistance. But just the phenotype and a dyslipidemia are more than sufficient. But by and large, the way I look at it is every type 2 diabetic has insulin resistance and should be treated adequately unless there is a contraindication to the use of pioglitazone.
Yes, sir. Sir, many questions which is relevant to what you have just discussed. I just want to highlight to one question from one of the reader, actually just related to what you just said. That he said that the patient is in insulin therapy since 4 years, and but TG is high, but NFLD is there. So what you suggest to reduce the
Well,
LDL and the TG?
he is on insulin therapy.
Yes, since 4 years, but TZ
Huh.
is high with NFLD. So, what you suggest on this?
Now, see, insulin therapy is not a contraindication to the use of pioglitazone. What you have to see is if he has a cardiac problem, if he has got a low ejection fraction, if he has got edema of heat, these are the conditions where you would not use a pioglitazone. If she is a female more than 60, postmenopausal, avoid using a pioglitazone. Otherwise, in patient who is on insulin, if you add pioglitazone, you might be able to knock off his insulin. In fact, that was one of the first papers that I published in the year 2002, where we used a triple drug combination of a sulfonylurea, metformin, and pioglitazone in patients who are already on insulin, because that was the time pioglitazone came into the market. And we showed that almost 50% of those patients, we stopped the insulin. And I developed a reputation in Mumbai that अरे पनिकर के पास जाओ इंसुलिन बंद हो जाएगा. So you can use pioglitazone unless there is a contraindication, like I said. But when you have insulin and pioglitazone together, or a sulfonylurea and pioglitazone together, the incidence of weight increase is much more.
Yes, sir. Sir, I will take the last questions on the interest of time. So, what is the dosage you recommend?
I generally use 15 milligrams pioglitazone across the board. And if the patient is very well controlled, then I might reduce it to 7.5. But when it comes to Nash or a fatty liver, I would use 30 milligrams of pioglitazone.
Yes.
15 would be inadequate, though all the recommendations are anywhere from 30 to 45 milligrams. But I would use 30 milligrams in patients with a fatty liver, whether Nash or a non-alcoholic non-alcoholic fatty liver.
Yes. Sir, before closing, I just want to any important highlights or summary you want to give to our doctor who's listening to you?
I think the only thing that I would like to say is the Indian population is an insulin resistant population. And if you treat insulin resistance very early in the course of their disease, you will save a lot of problems for your patients. Believe me, that would be the take home message. So start early with a metformin, pioglitazone, and an SGLT2. SGLT2 will neutralize all the side effects of pioglitazone beautifully. And plus, SGLT2 has cardiac benefit, renal benefit. Pioglitazone has anti-atherogenic properties, so it benefits every organ, right from stroke, heart, kidney, everywhere. So this combination would keep your patient healthy, fit, with no chances or very minimal chances of hypoglycemia for the rest of his life.
Yes, sir. Thank you, sir. On behalf of IJCP and USV, or today, International NASH Day, I will thank Dr. Professor Vijay Panikar, sir,
Thank
to
you.
give the complete discussion and the idea about NASH and NFLD and how pioglitazone will help to reduce the future event. And thank you all. And this program is supported by USV Private Limited on CME grant. Thank you, sir. And
Thank
thank you to
you.
all our teachers.
Thank
Thank
you,
you.
Sanjay.
Thanks.